welcome to our panel discussion, Silent Suffering, Ethical Imperatives in Neonatal Pain Recognition and Relief. So today we're really lucky to have three outstanding leaders in the fields of bioethics and neonatal pain joining us today. And they'll be sharing their invaluable insights on ethical considerations in recognizing and addressing neonatal pain. So our first jazz hands panel member is Michael van Manen. He's the chair in health ethics and the director of the John Dossiter Health Ethics Centre and an associate professor in the Department of Paediatrics at the University of Alberta. He also has a clinical practice as a physician in neonatal perinatal medicine at the Stollery Children's Hospital, and he's considered an international expert in qualitative health research. His research projects relate to ethical decision-making, the experiential life of the fetus and newborn, the use of medical technologies in clinical practice, medical complexity and technology dependence, and patient and family experiences of hospital care. And he's authored books, articles, chapters in the field of qualitative research methodology, health ethics, perinatal neonatal medicine, and pedagogy. And I'm going to stop now because there's just way too much to say about him, but you get the impression he's fantastic. Our next panel member, James Anderson, is a bioethicist and ethics lead for AI at the Hospital for Sick Children. He's an assistant professor in public health sciences at the University of Toronto and a bioethicist member of the Joint Centre of Bioethics, also at U of T. His research explores the intersection of ethics and technology in clinical research and practice, and recent work is focused on the clinical translation of machine learning applications in healthcare, the ethics of N-of-1 trials, and clinical decision-making in pediatrics. And last but not least, our third panel member, Dr. Rebecca Pillai Riddell, is the Tier 1 York Research Chair in Pain and Mental Health and Director of the Opportunities to Understand Childhood Hurt Laboratory in the Department of Psychology at York University. She's also a registered psychologist licensed to work with children and adults in clinical and health psychology. And she leads a multinational research program that studies parents and young children during stressful and painful procedures, with her research now focused on neonatal intensive care units. She currently leads Divert Mental Health, a pan-Canadian CIHR-funded mental health research training platform dedicated to inclusivity and accessibility through technology. Thank you so much to you guys for joining us today. And now just to introduce the topic for discussion. So, as I'm sure you know, many children spend their first days, weeks, and sometimes months in a NICU as a consequence of prematurity, congenital anomalies, or birth complications. And in a sense, the NICU can become their first home, where healthcare providers and their families aspire to meet their developmental, social, and medical needs. Advancements in medical technology, targeted therapies, and developments in specialized neonatal intensive care over the last few decades have led to a significant shift in survival rates for premature infants. And now 50% of infants born between 22 and 23 weeks who can access appropriate medical interventions can now survive. However, these advances in neonatal intensive care bring with them an undeniably greater and more invasive burden for the patients that they aim to save. Until the 1980s, a widely held belief amongst clinicians was that neonatal pain was almost non-existent. But research into the neonatal pain experience has, of course, strongly discredited this theory. However, the quest to improve understanding, recognition, and treatment of pain for neonatal patients who have no means of communicating their experience themselves and must instead rely on the response of their caregivers continues. And so for this panel, we want to reflect on the ethics of neonatal pain and suffering in the context of this silence. So I think it would be good to start with quite an open question, just to think about what do we mean by pain in the NICU, and what might be a starting place for us to think about this concept?
I'll start. Just so we have a sense of who's out there, how many people are like primarily clinicians, bedside clinicians, and have patient experience? And then how many of you have neonatal experience of any kind, research or clinical? Okay. So a little both on those sides. So I think building on what Lucie was talking about, this idea of defining what pain is. It's a really complicated question, and it actually is a philosophical question in a lot of ways. But when we think of it at the most practical, we know that pain is what the patient says it is. That's what we learn as clinicians. We get stuck in this paradigm with babies that they can't speak. And for a long time, that meant that they couldn't actually experience pain. We equated language with the ability to experience pain. And we know that that's not true. So then we think about pain and we then think, well, what else do we know about pain? We think about acute and chronic pain. It's sort of how units are set up. It's how we think about pain. But what do you do when, the standard definition of chronic pain, for example, is 3 months and babies haven't been alive that long. And so this idea of thinking about even acute versus chronic doesn't begin to capture the suffering and the pain that happens in the NICU, because there are all these acute procedures, but they happen so often and so frequent they can overlap. And what happens when there's no gap in the acute pain? Not to mention they have chronically painful conditions that are happening, like ED, for example. And so you have all of these different types of pain that are layered on top in the NICU. And trying to understand that. And then even as a scientist, and I consider myself someone who actually, I dance between basic sciences, I enter a program of research, and then also CIHR and SHRC programs of research that, take me across the bedside. But when I'm working with neurobiologists or I'm working with neonatologists, like to me, kind of on opposite ends of the spectrum of care, you end up having these definitions, these really basic conversations about who's actually measuring pain, who's actually studying pain. And there's an Indian parable, I don't know if you know it, about the blind man and the elephant. Anybody know that? But what it is basically, imagine having these blind wise men standing around an elephant, and each one gets a piece. So once someone gets a trunk, someone gets a leg, someone gets a tusk, and you ask them, like, what is the elephant? And they'll define very true to their experience and their study what the elephant is, but they're all parts of a whole. And so without that idiocratic synthesis, like within each individual, of how that comes together, the biological, the physiological, the psychological, and the social, without getting that verbal access, what is pain?
You already touched on the subjective nature of pain. Michael, I don't know if you want to say a bit more about that.
Yeah, I'd probably say the same thing, but just in different words, right? So if you say that pain is a subjective experience and that's your starting point, it's also important to realize that we often talk about it not as an experience, but as a concept, right? So if we want to orient towards it in the experiential sense, you need to put the phenomena first, not the concept. But like what you were saying, it's really challenging because babies can't speak. And even if a baby could speak, would they actually use the words that we use in the way in which we use them? Because they have a different subjectivity. Right? They're uniquely embodied in the world as a consequence of their development. Right? So are even words like anxiety, fear, or other uncomfortable experiences that we name, often under a much broader banner of pain, are they appropriate when describing the newborn? And it's even more complicated than that because we're dealing with premature newborns often, or babies who are developmentally different. Right? So does a 28-weeker, a 23-weeker experience pain, whatever that points to, as some kind of an uncomfortable experience, in the same way as a term? Right? How about if they're on medication, right? Invariably, practically, as like a neonatologist or a nurse or anyone else who works in the NICU, we're in this environment of, you could say, like reading signs, right? Dealing with signs. So for example, we see a baby being tachycardic, having a high heart rate. And we know that that could be because of dysrhythmia. They could have a pneumothorax. Maybe they're in an inflammatory state, or maybe they're in pain. But even to say they're in pain begs the question of, well, what does that constitute, right? So a baby who's, back in Edmonton, we have all these really long wait lists for procedures. I'm sure it never happens in the Children's Hospital of Canada.
Never.
I'm loving this phrase, Children's Hospital of Canada. I love it. It's so Ontarian. It's Ontarian. So a baby who's NPO for 6 hours because they're on the on-call list and gets agitated and the parents just can't seem to soothe them. Is that a painful experience? And how does that differ from, say, a baby who's post-op laparotomy for necrotizing enterocolitis? How is that, the texture of that experience different? My sense is they're different experiences, even if we can't find the right words to always label them out. And our approach to those situations are going to be different as well.
And I do wonder whether, because of that kind of multifaceted nature of different experiences and the different ways of kind of interpreting them, that sometimes that we take on the word suffering to try and represent that multifaceted experience. I wonder if we could talk maybe a little bit about is there a difference between pain and suffering? How would we distinguish between them, and does it matter if we distinguish between them? I think that was a nice segue.
It's okay, sorry. Yeah. That's the problem when you're sitting beside the moderator. You get to start.
Don't worry, I'll be leaning around.
I'll put my chair back. So, to me, pain and suffering they're different words, and they do mean different things. But there's a lot of overlap between them as well, and it's very challenging in the NICU world to cleanly say, when does pain become suffering? When does suffering become pain? Can you have suffering without pain? What does that look like? How do we approach it? Practically, maybe the starting point, I would say that when someone voices the word suffering, it often expresses that there's something about this current clinical situation that we're in, the current care that we're giving for this child, that's making us morally uncomfortable.
Yeah.
Right? So in that sense, you could say that suffering is, yes, it's about the baby. It's about what they're living through, but it's also about how what they're living through resonates with me, right? How I grasp it, right? So, we were joking before, if a nurse or a doctor mentioned, I'm worried about this baby suffering, that probably means an ethics consult is
This is what I was about to say.
Some kind of conversation where we're really starting to not just question a baby's experience, but we're also questioning the normative sense of the care. Yeah. Is it still good what we're doing? But that's, of course, just one interpretation.
Well, yeah, that's where I was going to say to you. Often the concept of suffering does come up in the referrals we see. I wonder if you want to speak a little bit about that.
As the sort of non-pain expert, it would be interesting talking to you guys about the podcast, because I realize that I think of suffering as it's quite blind that, but it's, I think, in some ways inconsistent with other definitions where sometimes see pain as physiological, as suffering is psychological, or something like that. And suffering is like an interpretation of pain, these kinds of ideas. And it's hard to make sense of that in the neonatal context, as Michael said, at least for me. But the key point for me is that I think, like Michael just said, when you hear about suffering, it's that, whether it's whatever the cause, it might not be pain. Like, so some of the hardest cases that we see, I think, are where you have a patient who is at end of life or nearing end of life, but their pain is well controlled. Right? So you feel that on balance, what we're doing is no longer a benefit to this patient, but you have to articulate in some way what the harm is of continuing. And you find, well, they're in pain. No, they're not in pain. We have a great, we have great pain specialists. There's no pain here. They're not experiencing pain. Sometimes they can't experience pain because due to brain injury, for example. But you still want to grasp it. You want to say that somehow this patient's still suffering. It's quite different than the psychological kind of interpretation of suffering, but that's kind of how it comes to me, is that even if we control for pain. There's no subjective experience of pain. There can be a sense in which this patient is suffering, and certainly a sense in which those who are caring for that patient in those circumstances are experiencing distress, woe, etc. And that's expressed in saying we feel this patient's suffering. There's kind of an imbalance of harms and benefits that's no longer justifying continuing in the way that we are proceeding.
Sometimes parents will say words. Sometimes I've heard nurses say the expression, I think we're treating the parents now more than the baby.
Yeah.
Hopping around like the end of life when we're, giving medications because we're hearing the baby breathe in a particular way or their color in a particular way.
Yeah.
And that to me really does speak to how, the person who languages a baby's experience as suffering, their experience is often very much connected with what the baby is, what they think the baby is going through.
Yeah.
I can't think of a time where I've kind of argued with a family about is the baby in pain or not, but certainly many times where we've had discussions talking about what they're seeing and what it might mean or what it might represent.
And we all bring our own values and experiences into these interpretations and these conversations, and not just our values and experience, but also our own kind of implicit biases around if this is happening, we should do this or we shouldn't do this. And I think it's a really important thing to maybe talk about now is like, how do we manage that? And how do we make sure that we're acknowledging our own biases, our own values, whilst doing the best we can for both the patient and the family? I don't know if you want to talk about that, Rebecca.
Yeah, like I think so. Getting back to this idea of not, we can't avoid pain in the NICU. The question is, can we avoid suffering? And so I think that one of the challenges, so I'm a clinical psychologist, and when I'm working with older children or adults in chronic pain, we talk about, your choice to feel, this pain, this physiological sensation of pain is not a choice. But in, a type of therapy that we do, acceptance and commitment therapy, we think of suffering as a choice. And it leads to the interpretation, right? At the most basic, like think about a little girl going to get her ears pierced that she really wants. That's way less invasive. That's way more invasive than a vaccination needle. But I'm going to tell you, they're going to suffer more from the vaccination needle than they are from the earrings, right? So it's about that subjective context, something that I don't believe, the preterm infant can fully comprehend. But at that same token, where it gets dicey, and when I was coming out, when I first came to Sick Kids to work with Bonnie, in the early 2000s, this idea there was a research going on and ethical dilemmas about do infants even feel pain if they can't be conscious of it? And it's these questions about what is the subjective experience, like interpretation, not even just experience, but the subjective interpretation. And if you say that infants aren't capable, then therefore they're not deserving of pain management, for example, because it doesn't matter. And it was only in '87 where the first paper came out in the New England Journal of Medicine that said, hey, babies feel pain. Like it was being done, open heart surgery was being done without analgesics and anesthetics on infants quite regularly at that time point. But I do think when we think about, what do we do? I think that what infants go through is even worse than, I don't think there's a word for it. And we have to, and I think that's our responsibility. There are other developmental scientists who talk about like taking an ontogenic perspective. And that's the idea of thinking about language and thinking about definitions, not from our interpretation, but from the perspective of, for example, the infant. And so when infants don't have the capacity to reflect on past, present, and future, it means they live in the moment. And if they're feeling pain, physical pain, which I think we all would agree, nociception is happening and capable, then that's all they know. They know no end, no beginning. They know that moment. So to me, even if I would theoretically say, are they suffering from an interpretive perspective? No. But what I think they're going through is, to be honest, much worse. And therefore that much deeper the need, the ethical imperative to end the suffering, like to end that.
And I think that lack of autonomy is very uncomfortable for us, where the baby can't do any. We again, comes from our own values, where we perceive there's no choice for the baby. The baby can't say, I don't want this anymore, or they don't have that kind of autonomy to make a choice about what they want. And for that may be us putting our own values again onto that baby, as you were talking about this morning. But that, I think, is the thing that really sits uncomfortably with us as clinicians sometimes.
This is all, it's interesting, right? And it's challenging because so many of these questions we're never really going to be able to answer.
No.
And I don't mean that in some kind of negative sense. It's more practically we have to somehow work with situations where we're only able to incompletely answer questions. At one point we were chatting about, well, does a premature baby ever really want something? Do they experience wants? Right? Honestly, we don't really have the developmental literature to say, do babies experience want? But perhaps we have the developmental literature to say they experience something akin to need, right? In the sense of, they seem to calm in response to things that are familiar. And I mean familiar again in kind of a broad, kind of vague sense, right? So when you see a baby calm in response to their mother's voice, for example, or the smell of their parent, or other things that have some sensuality to them, I think you're obligated to reflect, at least in a tentative manner, that there is something meaningful, something sensual about this existence that they experience. I mean, the developmental studies that point to, premature infants being able to recognize melody, right? Like orient to one melody compared to another that was heard over and over again. That to me would suggest that, they experience something akin to anticipation, or, kind of pretension and retention, to use like more technical terms, right? So they don't necessarily just exist in that moment, right? But there's some kind of a sense of anticipation. So what does that mean? When you go and handle a baby, how do you approach them, right? You don't just undo their swaddle, remove their bedding, and just get at them. But you're cognizant to the fact that they may experience something in me coming in contact with them. So to me, thinking about pain and suffering, they're useful words if it ultimately humanizes our care. Means if we treat babies like babies, rather than so-called, neonates.
Yeah, well, we
right?
talked about that the other day, about that language that we use in the clinical sphere, and how it does dehumanize that experience. And in some ways, maybe that's self-protective. You mentioned the word handled, for example, and instead of touch or hold. And I think it's really interesting to think about that type of language when we're experiencing newborn babies in the NICU.
I think it also calls into questions like, for me, when I think of, how NICUs are designed, it's very odd, right? Here are these little babies, little children, who are being taken care of, often in little plastic boxes, with no place for their parent to truly be beside them. How would that be okay in any other area of pediatrics, right? Like, that speaks to something about how we regard these newborns' experiences. So, institutionally, structurally, you could say that we discriminate against the experiences of newborns because we aren't able to fully grasp.
And that brings us back to this idea of bias, I think, again, like in terms of how we think about pain and babies in the NICU and all of that. I don't know, one of you would like to talk a bit more about that?
I mean, bias in the sense of like systemic error. I struggle a little bit with the word bias in the sense of it implies that there is some truthfulness, right? Some gold standard. And I think that's what is challenging also for pain, right? You still have a certain degree of unknowingness, attentiveness when you're talking to the experiences of children who are pre-verbal, or don't yet have the capacity to voice their experiences, and we're forced to read their behaviors or other physiological signs.
But we're not doing that in a vacuum, which is super interesting,
Sure.
because our own, as I said before, like our own experiences color how we perceive the experience of the baby. And I guess that's what I mean. Maybe that's a better way to describe it.
And for me, I mean, I would say that's almost like an ethical tension, right? You know, because we see that sometimes where some parents are very, very sensitive. And I don't mean sensitive in a bad way, but they're very kind of present, they're there, and they're aware of how we're handling their child. You don't just walk into one of those rooms and examine the baby because it happens to be 7:30 and that's when you examine babies, right? If the baby's having a nap and sleeping, you wait for them to wake up. But then maybe in another room, the parent's not, and we just engage in those activities. So I do think that we do run into situations where we treat babies very differently as a consequence of their parents, rather than recognizing that, you know what, you really should never wake up a baby from a nap to examine them unless you have a really good clinical reason to.
I think this is a good point for you to jump in.
Yeah. I think that, so for the past 20 odd years, I've been looking at the bias of caregivers, and I think it makes me worried for the protection of infants, because what we've shown is that, and it makes sense, right? Like whenever you're making any sort of judgment about anything, if you're more stressed, you may make different decisions. You may see, and we'll kind of use the word like threat appraisal. Like things may seem more dangerous if you're more stressed. So what we've found, and we've done sort of looked at people who are judging their own babies, and we've done sort of little tricky, we call them quasi-experimental studies, where we kind of gave them a whole bunch of babies at a whole bunch of different ages. And we got parents, nurses and physicians to judge the babies. And then we said, you know, how much pain do you think they're in? But we asked them other questions as well. What they didn't know is that actually we had already objectively measured these babies' facial activity, so that we knew that they were all experiencing, you know, if we were going to use verbal, like 8 to 10 or a 10. They were babies, we use facial coding, the neonatal facial coding system. That's how we kind of do assess pain in these babies. And so we knew that they were a lot of pain, but there was a lot of variability. And so things did actually impact there. And that was where we knew we controlled everything, but we saw the same effects when they were judging their own babies, that we could actually ask them how depressed they are, how stressed they are about, you know, being a newcomer, for example, or for being not agreeing with North American culture, like questions, we call it culturation questions. And their level of stress with all of these things impacts their pain judgments. And so we could also, like when we were doing it, we created the largest cohorts in the world, looking at parents and children in vaccination from 2 months of age to 5 years of age. And so we actually videotaped. So we did have kind of like I call it a proxy truth, because we don't have a ground truth because we can't ask them, but where we know that they're upset. And so bias is a major challenge. And we were talking about this idea of being protective, like using language that may distance ourselves. Well, talking now more and more, now that I've gotten to come back into the NICU full time with my research to really focus there, you know, understanding how caregivers, like how nurses, and what it's like for them working with babies at the edge of viability. And so, you know, it's very stressful on physicians and nurses. My research is like centered right now at Sinai, but you know, like they had the world's most premature twins born. And you know, these are miracle babies, but there was a lot of, like, they perceived a lot of suffering in those babies, again, using that. So this idea of needing to be, and they talked about it in the 80s, like kind of an institutional desensitization. Because if you're working with the sickest of the sick, the most vulnerable, day in, day out, every hour can be a life, you know, someone's on the edge of life or death. Someone, right? That's fair to say, I think, at our hospitals, like any of these hospitals. It takes a toll.
And I think it takes a toll, not just in that sense, providers' distress, their resiliency, we think of compassion fatigue, burnout, but it also affects how they see babies over time, right? So, you know, it's unfortunate that we can't advocate for those healthcare providers who work in, you know, very high acuity environments, the level 3, the level 4, they can't also spend some weeks of every year working in a level 2 environment. Because although we're talking about, you know, NICU being like this dark place, let's not forget the NICU, by and large, for 95% of the patients that we care for, it's a happy place, right? It's a place of like new beginnings of beginnings, right? And don't get me wrong, I know even the babies who are born late preterm, they go through procedures and interventions. There's aspects of normal life being disrupted because they're not against their parents' skin, right? The environments often aren't designed. Parents can necessarily sleep overnight, or even if they are, we don't have the social structures in place to support that family if there's not resources for, you know, caring for other children or work and so forth. Right. I totally lost my train of thought. Totally lost my train of
All
thought.
bad.
It isn't all bad, right? It isn't. So I think on the one hand, it's important to think about those cases that keep us up at night, those ones that sit with us and stay with us, where we really questioned, did that child suffer?
Yeah.
Right? But we should also think about those everyday moments in the NICU as also areas where we can, you know, make gains in our practice.
Yeah.
And what I advocate for is that, yes, we recognize pain, but we try and regard that it's not simply pain. There's all these different things that come under this umbrella that we can respond to.
I think you get left with this moral residue over time of dealing with all of these cases that just stick on you, and you know, you carry them forward into every single thing. So I think it's really important to both process that as well as trying to focus on the good, and the good, not just the good of outcomes, but the good of what you're doing in caring every day for those babies in a thoughtful way. But that kind of tension, that moral residue that we carry forward impacts sometimes our relationship with parents in this kind of situation. And that's, I think, James, like often where, you know, you might be called in terms of this feeling of values conflicting about how are we doing the right thing in looking after this baby and managing this perceived pain and suffering.
I was just thinking about, just before I get to that, that most of my experiences in this area, well, so first of all, the bias piece is that as a bioethicist at this hospital, and I'm involved in situations involving pain and tensions with parents. It's usually tensions between the team and parents about pain management. And it's important to point out that, as Michael just did, that these are rare, you know, infrequent things, thankfully, but we don't, certainly don't see like things like good cases, right? It's always when things have gone off the rails.
Yeah.
And so that influences how I approach this kind of situation, because you're always being thrown into these very tense, difficult situations, right? So that's a bias that I've had to unlearn to some extent, because the first time I saw this, it wasn't with a neonate, it was with older, like a teen at end of life with cancer, intractable pain, and parents refusing pain control because they wanted to interact with, they didn't want their son to be sedated in his last days so they could interact with him. And I found that very difficult, and I still find it difficult. I think we should always find it difficult, probably. But over time, I've come to see that, you know, that's understandable. It's to some extent reasonable. We have to be careful, obviously, about how far we're willing to go with that. But I just wanted to say that as part of kind of where I'm coming from, kind of a bias in terms of my experience, at least, the cases involving pain and tension around them like this. But the other piece is that even, you know, pain generally, not just with wounds, is a contested place. Like, it's people adults who express pain are sometimes, I don't know, frequently they're treated, their skepticism, you know, about whether they're actually in pain or they're just malingerers. You know, there's a long history of this as well outside of the neonatal context, which I'm only dimly aware of, but I know it's a part of the sort of pain literature, right? So it's interesting that, you know, we're focusing on neonates here, and it's like exacerbated even further because a neonate can't raise the problem themselves. And even if they did, we might doubt them, as we do with older people sometimes. So there's like a broader cultural problem there. Like you mentioned that we're trying to teach that if someone, you know, mentions they're in pain, we should take it seriously. But and I think we do better maybe than we used to, but it's still an ongoing challenge, I think. And that's because of the nature of pain. It's like it's subjective to some degree at least. And so this problematizes the tension kind of point that you're mentioning, right? If you have disagreement between substitute decision makers, typically parents, and the team about what's adequate pain control, how do you deal with that? And I think, you know, even just with talking with you guys, like the preparation for this, and even in other sessions this week, because we've had numerous sessions about pain this week, because it's Bioethics Week and Pain Awareness Week, and it's, you know, attending to the infant in this case, right? The baby can tell us a lot if we listen, and even in areas like this where we're having disagreements, like we can, in some cases at least, be flexible. And we can move in one direction or another, but always like paying very close attention to how that affects the infant. You know, so we're trying to work with parents, but also keep the neonate or baby at the center of what we're doing. And that's a very difficult balance. I won't say it isn't. And I think sometimes, honestly, I still feel like we attend too much to parents' wishes in these contexts, which sounds harsh, but, you know, we can't lose sight of the suffering, the pain of the patient, the infant in this case.
Which brings me on very nicely. That was nice. Yeah, go for it. Then it'll bring me on nicely.
I think it really needs to be acknowledged that NICU is very much a relational practice, right? Whereas healthcare providers, we're constantly mediating this relation between parent and child. Right? So if you look at a lot of the qualitative research that describes the parental experiences of having their child taken away, right? As, you know, being a stranger to the NICU or a foreigner to that place,
Yes.
we can appreciate part of what we do in NICU is not just, you know, welcoming the baby into the world and supporting them. We're also welcoming parents, and we're trying to support them in that.
Yes.
And it's not just a relational world, it's a technologically mediated relational world where all these other things affect a parent's way of knowing their kid.
Yes.
So, and increasing the research is showing us that even when a baby is born, they're not necessarily truly separated from the body of their
Yeah.
right? So a parent who's under stress, you know this research, I'm sure better than I mean, their breast milk changes in response to that stress. Even some of the pheromones that they release, right? And a baby's not numb to that, right? So yes, on the one hand, we have to be patient-centered, right? Put the child first. It's not the same as family-centered care, right? Those are different things. Family-centered care is treating the child in the context of their family. But we also have to have this relational awareness that if we don't also care for the parent, that is going to affect the care of the child. Because they're not necessarily really separated in this particular, which is what is unique about the ethics of NICU, I think, compared to any other place.
Yeah, right. So I have so much to say, but I don't know, like, I feel like I could just go on and on. We're just kind of looking at like.
May I have your attention? May I have your attention? May I have your attention? Code wide atrium emergency department. Code wide atrium emergency department.
Yeah, so even just thinking about one of the best ways to manage a baby in pain in the NICU is skin to skin. These acute procedures and putting them into skin to skin. But for that exact reason, we unintentionally kind of doing, because with all this now, patient involves research. You don't do a project without a patient beside you. So we've been talking to patients and we end up on these very different, and I'm writing grants for things I did not mean to write on, because they're teaching us and showing us. And so, you know, you just say, I've always thought of skin to skin as just this most beautiful experience. You see the videos. And then mother started talking about how petrifying it is.
Yeah.
And we were just like,
They're afraid they
yeah.
Yeah.
Oh, and they've done it and they've had fails and so we have a paper coming out in pain this month. It was just accepted, you know, on maternal sort of perceptions of skin to skin with the very youngest baby. Right. So looking at the very and extremely, it's a very different thing than when you think about, you know, like the bigger preterms or even like a full term chub, you know, we call them in that, you know, like where when we were doing 2 months and you're seeing them doing skin to skin or breastfeeding during a vaccination, it's like the most magical thing you've ever seen, where it's different when they're highly medicalized. And then the context and that there are alarms constantly going off and the baby goes, you know, tachycardic or bradycardic, you know, like any of these extremes happening, and you start wondering, is this best to move? And when they're older, we've shown research to say that it, you know, there's benefits to having skin to skin with the parent. We've looked at their brains, and their brains are more protected when you're doing it. But if they're getting so stressed, you know, and the mother is stressed, then when the baby's in skin to skin and their heart is beating so fast, I'm actually wondering about like chemical signals that are being sent between parent and infant during skin to skin when the parent is so anxious, which is only like 8 to 10%, I'm estimating, would be so anxious that it would affect their physiology. Because there's the first time jitters, taking them out and that sort of thing. But there's a group of parents where it's very different. And so this idea of treating the mother, and for me, I as a clinician, I could never pick a lane. So I did infant mental health and maternal. Like I just wanted to do both. And I never make sense in my brain, but it makes sense now when I see it makes sense now, I think, but like the way psychologists are trained, you're having to do double everything. But it makes now when I see where I've ended up, it just makes so much sense.
You know, one of my mentors, he would say that this just speaks to the need to individualize care, right? I mean, papers are challenging, right? They tell us what happens on a population level, but every parent's different, just like every child's different. And sometimes when we find something that's challenging or stressful, it also comes to thinking about, well, how is it that we support parent? Right? For that very anxious parent, is the first time, you know, is it done during the day when everyone's busy and everything's loud, right? Or could we take the time to do that in an evening when things are relatively quiet, right? Could we use a mannequin or something else, even just so from a body perspective, they have that sense? Could it be done by a nurse who hopefully is some rapport? And there isn't that added sense of, you know, maybe cultural differences of, you know, being exposed, right? What if someone has a history of trauma? How do we affect that? So it's so much more complicated, right? And in a way, I'm going to read the paper, but sometimes I worry when we take something very human, like holding your child, and we medicalize it into an intervention like skin to skin.
Yeah, exactly.
You
Right?
forget
Because
there's the mother.
Give it a label, kangaroo care, like, you know, I mean, and we know what we mean by that, but then for parents, it becomes a thing rather than just touch.
And holding your child can look, there are many different ways of holding your child. So we also have to recognize you're holding your child, maybe just from being there with your voice, right? Or putting your hand on them. That can be a holding experience for your baby. And celebrating parents who are able to do that.
And I think you had mentioned this before about sometimes
in the sign.
the sign, okay. sometimes in the NICU, parents it's their first time of having that role, and it's completely not how they were expecting to take on that role as a parent. And so they don't feel like an authority for their child because they're in this foreign environment and they don't know what's going on, and they want more guidance from start. Do you know what I mean? It's like how do we decide who is the authority in that circumstance where every case is so different, but everyone strongly wants the best for?
I would say that's the wrong question to have.
Would you?
Yeah, I wouldn't say who's the authority. It's
What would
rather,
you say?
I mean, how can we support parents to feel like they don't need to have to hold their child?
Yeah.
They don't need to have to touch their child. Rather than saying who has authority, I don't know if that's
We like
really
to say that though, don't we?
I do, but I think that comes back to, when
Yeah.
we were talking this morning about Christine's work, is we have to also be thoughtful of the kind of questions we're asking.
Yeah.
What's going to help us move forward? And one that kind of positions parent against healthcare provider. I know we run into these exceptional situations where we involve legal and other things, but the majority of the time, a parent's and their child's interests, right? So how can we support? And we also should acknowledge that some of the challenges that parents experience is not just because the baby's born premature, it's because how we act as healthcare providers, right?
Definitely.
I want to hear about AI.
I don't want to hear about AI. Would anyone like to talk?
Are there any questions? I feel like we have 2 minutes left. 1 minute left. Sorry.
Okay, yeah, please, feel free to jump in. Yeah.
Okay, so
Oh, hang on. I need to be embarrassing and get my.
Okay, so I came to this talk because I have like a very personal experience with, I was a NICU baby at sick kids. I grew up in sick kids and I grew up to have some chronic conditions because I was born prematurely. And I kind of want to know, like, from an ethical perspective, like, because like from my experience, what I see is that once you become a chronically ill patient, your pain becomes like, say my pain on a daily is a 7 and I'm going to the ER and I tell them it's a 7, but I'm going there often. So they know that my like baseline is now a 7 compared to like someone who's never experienced that kind of pain. Like I want to know like how like hospitals here like prioritize patients based off of pain. Like would you say someone who has a chronic illness, because they're so used to and habituated to that pain, they can like wait longer to see a doctor in the ER compared to someone who's never experienced that kind of pain? Because from my experience, it's always been like, oh, like if it's a chronically ill patient and they're coming in specifically for pain management, they're seen as like needy, or they're seen as like, well, this person is used to this kind of pain. They come here for this complaint often. They can wait and someone else can go like ahead of them. Like, I want to know, like, because like they always kind of like ask you to like rate your pain like 1 to 10, which to me also, pain is not a quantitative thing, it's a qualitative thing, because like it's affecting your quality of life. It's affecting not just like your like biology, but like your social life and like your mental health and other aspects of it. So yeah, I think I just went off a tangent, but if you could answer that.
Thank you so much for sharing that. And that was actually something that we were hoping to get onto eventually. So I
can jump. I think it's really helpful that you began by pointing to chronic pain, because to me there are certain labeling that goes around pain which affect certain biases in care. And I think you're very right in voicing that if you go into an emergency room and you identify yourself as a chronic pain individual, if the nursing staff looks in you and they take out that little scale and they say, well, her face doesn't look like a 7, I'm not going to believe them. That too reflects a bias, right? It reflects a bias when we use behavioral markers to judge someone's subjective experience, right? Which calls into question all behavioral research in some way, right? Because like you said, pain is a subjective experience. I'm not an expert in, unfortunately, anyone who's walks and talks anymore. So I don't think I could speak well to chronic pain management, but I would reflect on your words by saying, from an ethics perspective, people need to be aware of their biases, right? And ideally, we need to look at institutional practices that support people so their care is not affected by other biases.
And to minimize the risk of epistemic injustice, whereby you feel immediately that someone is suspicious of your experience and makes you feel awful. I'm sure, like, I don't know if you want to.
This is what I alluded to before. I think this pain, these challenges are not just with neonates. So I'm very sorry you're experiencing that, and thank you for sharing it. I don't think I have a huge amount to add in terms of what Michael just said, but yeah, I mean, I think raising it and advocating and certainly this can help do that. You shouldn't feel like you're being sort of shunted to the back of the line just because you deal with this all the time. It's not fair. So, but yeah, it does reveal something about pain experience in our societal biases around it, which is a struggle that we are still working through. Thanks for sharing.
Yeah, it's such a complex thing when you're talking about having your voice being heard, and being, because on what you're talking about is being the good patient in that way, and having that work against you because you handle it well. And pain is tricky, right? And I just want to acknowledge just like how tricky that is, because when you go to an emergency room in pain, there's that catch-22 is that the squeakiest wheel in emergency is going to get triaged up. But on the other hand, as you get older, get into as a child is different than when you're older, because then the idea of drug seeking behavior comes in, right? And so it's a very tricky place to be, a very hard place to be. And I hope that being a good patient and being able to, a 7 doesn't mean you're habituated. The psychologist to me, that's not habituation. That's chronic and constant. That's pain. Habituation is when you don't feel it anymore. And I think your pain deserves attention.
Just to add on, because transitioning from pediatric care for pain management to adult care, adult life, I feel like they should teach youth at the age of preteens, teens, how to advocate for themselves, because I struggled with that a lot, because once I became an adult, it's whatever my parents said that wasn't being heard, they were like, I have to speak for myself, and I was very shy and scared, and I didn't know how to explain what I'm feeling. So I feel like that's a component really missing in hospital life, where you don't teach that transition to youth, how to become an adult and speak for yourself, because if you're not gonna be able to talk for yourself, that can lead to misconceptions and miscommunications that can lead to further trauma, and that can lead to that young adult not even seeking care when they need to, because they're too afraid to go by themselves or speak for themselves because they feel like they're not being heard.
Yeah, I fully agree with all of that. And I was also a patient at Great Ormond Street Hospital from birth to 16. I totally know exactly what you're saying, and I think it's an area that we need to.
There's work in this area, but it's not. I mean, we do work on it, but it's still. And some places do it better than others. Some units do it better than others. Some specialties, etc. So
that first step of recognizing transitional experiences, whether they happen from adolescence to adults or even between care environments, right? I follow some families for some time after they leave the NICU, just from a primary perspective, and seen them transition from the NICU to the PICU, or the NICU to the PCICU, and the pediatric unit, and then they text me when they're home. It's very different cultures that they're navigating as a family, and their child's kind of existence as a child is looked at differently in different places. And when you become an adult, you're right, there's all these different transitions, and we have a responsibility as healthcare providers, not just to treat our patients in the moment, but also to support them for those transitions when
Yeah.
they come to.
We always want to try and take steps to promote autonomy all the time, but it's just clearly something that we need to think about more in practice. Thank you so much for sharing. Have we run out of time now, Liz? Or we got a bit
7
more
minutes
time? Oh no. Well, thank you so much. Thank you guys. That was a really amazing discussion, and thank you everyone for coming. I'm sorry that we couldn't talk more to you at the end, but really appreciate the discussion. So.